I can hear you. I got you.
That was hard.
Oh, it was that?
It was so hard.
Oh, man.
So hard.
Oh, man.
The highest is an 80%
Oh,
so
yeah?
far.
Yeah.
Okay. So we will see what we will do.
Everybody fell.
Okay. Okay, good. So,
Got the signage.
yes. Okay. So, okay, so we start from there. Or whatever.
I was gonna bring. I was just gonna bring these up to. What was your wrong?
Where did you go? I'll be back. I just need to turn in a check to
Okay,
Dr. Nelson.
you sign up on sign up sheet because later on they
The
will take
surveys?
it. I mean, no, there is a sign up sheet.
Oh,
I
attendance?
give it to here. Yeah, sign up. Then whenever you come back, then you okay, see you happy.
When are you available at all today?
After the class.
Yeah. Are
Yeah.
you going to be in the office? Oh, we have a class after.
You have class after?
Yeah.
Okay, so what time you want
Do
me?
you leave during lunchtime? 12?
At lunchtime I'll leave, but I will be back in about,
I have a break from 12 to 1.
From 12 to 1?
Yeah.
You have a class?
I have break.
You have break. So how about 15 minutes to 1?
Okay.
Do you think that it
Yeah.
will be enough?
Yeah.
Oh, that's good.
So,
I'm in my office,
where is that?
which is in 4th floor.
Here?
Here, 4th floor, and room 416, something like that.
Okay. So,
can ask
at
Debbie.
12:45?
12:45.
Okay.
Is it okay with you? Or do you want to come sooner than 12? Which one is
No, that's the only time I have break.
Break,
12.
okay. So
Yeah.
12
It's about,
o'clock.
it's about the test.
Okay. No problem, no problem.
Everyone.
Okay.
Everyone.
Yeah, because I need to know how you want it. I mean, the final one. That will be great.
Okay.
Are you the representative?
You're talking in the microphone.
Okay. So, are you the
Yeah, I'm the class
student?
president.
Okay, yeah, I need to see you.
Okay.
Okay, good. Okay. So, good morning.
Good morning.
So, I wonder why it was. So, I need to know how do you want the exam? Because I tried to give each question from the book so that it won't be outside the book. And I tried to give you some hint to if you didn't read that, you can pick the right answer. So I will be glad to know your input. Now, right now, we don't have much time, but yeah, I will be glad to get your input so that in final everybody be happy. And I hope that right now also you get happy. Okay? So because the main thing is that you learn the subject, which I hope that by now you know these things. So, yes.
We thought you were going to bring review questions like from the book because we looked at the book review questions and they were nothing like the ones we saw.
So what
We
do you mean
studied
by...
everything.
Yeah, everything.
Yeah.
I used the book.
Yeah,
Yeah.
But then the book gives us review questions.
Oh,
So
review.
we thought they were going to be similar or those type of
Oh, so you
So
get
we
that.
studied those, we studied
Oh.
all the slides.
Sorry for that. Yeah. So no, I didn't use review.
But they would be like the same level
Yeah.
of those kind of questions. Not the same exact question, but the same level of those.
So I can change, the kind of question. Just giving a sentence. In other words, you put one word over there. If this is confusing for, multiple choice question.
No, we like multiple.
You like, okay. And I hope that multiple choice also likes you. So there will be no problem. Because we do have different kinds of question. One is matching, which you match. You have everything,
Just
then you
multiple
match.
choice is fine.
So, I will be glad. Yes, please.
You can finish. Multiple choice is just fine. It's just that, we didn't have a correct study guide. And with the amount of slides, I think, and it's doable. I was studying 3 days straight for this test, and I got a 21. So I feel like the test questions were not closely related to what the material was. And I think maybe a study guide that actually goes with the exam would be.
Oh, so in other words, you want study guides. That's why I gave you these. You choose. If you want study guide, I will give study guide, but I will reduce my presentation.
No, that's fine, but not like the study guides that you had, because those were not really study guides. They were just reading information.
Okay. So, let me know how do you want it. I will try to adjust, but I need your idea. Yes. She first. Yes.
I think the overall theme of everything is that it's the whole book, and then there were 600 plus slides to study. So we did a lot of studying in our class, at this point in the quarter, we're capable studiers. It just was, I think we need more of a streamlined information of reduce it down to just what's important, state board type things, what's gonna, because at least for me too, that's how I felt like I studied a lot, and then on the test, there were questions that I just hadn't even, I felt like I was trying to study things that had to do with the periodontium and more like profession things, and there were questions that I felt were really unrelated to state boards or
Do you remember which question was that, so that I will?
There was a question about 2017.
Like the study question, it said in 1977 they use this term, but they don't use it in 2019.
Yeah.
So that was kind of
So you don't like those things, okay?
just I think
No, anything else?
when we talk about like a study guide, just more. We're not asking for a handout. We don't want a study guide that's just the questions, but just like a boiled down, reduced study guide that we can study, and all of that information that's in sub 30 slides is what's going to be on the test.
Okay, sure. Yes.
I understand that you had mentioned about the book, but your assistant, also mentioned that to really focus on the slides, because there's a lot. The book is with all the other studies, to focus on the slides and the book, it's a lot. And your assistant had mentioned that the slides, 90% of it, she said, would be the slides, but the slides didn't really help that much. I would say. Now, if for this next test, should we not even pay attention to these slides? Because I need to streamline my studying efficiently here, because getting close to finals will be a lot.
Yeah.
Am I just reading the book, focusing more on the book, and these slides are just for presentation's sake?
Okay, so that's why I want to know all of your idea. So in other words, you want to know whether you should focus on whatever I present or I give you, or on the book for the next test, final exam. Okay.
I would rather everything be on a PowerPoint. Everything that you teach in class is on the test, and we don't have to supplement
I
random
agree
things
about
in
that.
it.
Okay,
Your
so
important things on the PowerPoint, and that's what you draw for the test.
Yeah.
okay. So in other words, whatever I present here. Okay.
Lecture equals
We had another class, it was head and neck anatomy, and for the final, we did the questions at the back of the book. We had to know all of them, and those were our final. And for this exam, we studied those questions. It was more than 84 questions. we studied them all, but they weren't on the exam. So maybe for the finals we can do those questions with the quiz questions you give us, and we will have more than 200 because we already have 85 something.
Okay, so for the final, you do have how many? 1.5 hour. So if I give you, I will give you not more than 90, so that you have enough time. So I won't give you 100 and something for the final.
But you can pick from these questions, and we already studied them, and they focus on the main material, like the material that we need to know.
Okay, so the other way is that I gave you, question in each session. Multiple choice, and then at the end I select on that. That's another thing.
Yeah.
But in that case, it will be too many questions. I can do that.
It's better than studying 3 days.
But if it helps you, I will be glad to do that. But for the previous one, I can't do that because it takes time.
So for the previous one, we picked the one from the book, 85 questions.
So where is that? Because I never use that, so I don't know where is that. And the book is new.
We have those questions.
Oh, you have? Okay. So I will see that.
We can
Yes.
share them with you and you can see them.
Okay, so I will see that. Anything else?
Study guide. It's not like the study guide that you posted, it's different. So that means one topic is important, they mention that topic, and then they're going to ask any question related to that topic. But the study guide that you post, that was different. So it didn't help.
Okay, so yeah, it didn't help. I understand that. Because I went to the book and I got certain things on the book. I went all on the book. So that was that. But you don't want that. You want something that I present and you want from that. Am I right?
Yes. Yeah.
Okay?
Yeah,
So that's it.
it's more condensed.
And even you want a question, which I'm trying to give you these tested, this quiz before, so that you know how the question will be that. And maybe you want also some question from these tests, in other words, quizzes.
Like they're on the quiz and then it would be again on the test?
On the test, something like that.
Yeah, that's a good idea.
If it helps you, make you happy, because the main thing here is that you get the information and you know what's going on. It is not that how much you don't know, it is how much you get that and test that. So I will consider anyhow. Any? Yes.
I think another thing too that's a big stress right now is this test. When these grades come back to you, would you consider curving this exam?
I will see that. Yeah.
Okay.
Because I need to see how is that and how can I do that.
Okay.
Because my main intention is not to fail. No, that's not the main intention. The main intention that you grab the information, even on the test, you grab the information. That's the main intention. And you can retain it. In other words, use it in the clinic.
Yeah,
That's
and
more
I think
important.
That's what we want is just boil down to the information we need specifically for clinic. Like
For the clinic, that's very important. So today the topic we have, okay, so everybody feel that this is very important because I need to see whether I should eliminate most of my material on here and put it in study guides, or I don't do study guides, I go on these, and then that will be enough for you. Which I think right now it is more than enough, because I do have too many slides on here, and if you want study guides, that will be more than that. So I will give this to Debbie, so everybody participate, because this is very important. In other words, the main intention is to see if everybody or most of you want study guide, or do you want a good presentation here or less presentation here, more on that.
Do you have any more empty ones? Do you have any more blank ones?
No. No, I don't have. She didn't left anything here. No. Okay. Anyway, thank you very much for putting your time, and thank you that you study this material, and I hope that they will be of help in your clinic. That's the main intention. And you can retain those information and even get more information from whatever. So let's go to the topic, because I don't have much time for periodontitis. So the topic today is periodontitis. So let me see if this works. Yeah, this is backward. This is forward. So periodontitis, in the past it was called pyorrhea. Just when you go to the old book, 1930 something or 20 something, you will see the term. You don't see periodontitis, you see pyorrhea and even Schmutt pyorrhea and so forth. Classifications start from those time, and then the new classification is 2017, which is gathering of lots of periodontists. Thank you. From around, the whole America and Europe and everywhere. And finally, starting from 2015 and finishing in 2017, according to that, they came to the classification for periodontal disease and periimplantitis and conditions. They classified periodontitis into necrotizing periodontal disease, periodontitis, and periodontitis as a manifestation of systemic disease. Now, before that, in 1999, we did have what we called chronic periodontitis, and then aggressive periodontitis. They classified the periodontitis as chronic periodontitis, aggressive periodontitis. Then it was sub-classification as slight, moderate, and severe. Now they use stage to define the severity of periodontitis. They are not using slight or moderate or severe periodontitis. Now we use stage 1, stage 2, stage 3, stage 4. And it shows the severity of periodontitis. And by that, we mean that the worst situation in the mouth, even if one tooth has a situation which can be classified as 3, it will be stage 3. So that's about the periodontitis. Now, periodontitis, you will see these terms also in the books, which you see chronic periodontitis, aggressive periodontitis, localized juvenile periodontitis, which in the past it was called, then they called it aggressive periodontitis. So you will see like that. Now, do not rely on clinical appearance. In other words, in the case of periodontitis, you might see gingiva which is like this. And now, periodontitis is the disease of what? Of bone. Gingivitis is disease of soft tissue. Now, when bone loss happens, then it is periodontitis. Now, you will see a case like this. Now, do you have any comment? Young lady over there. Do you have any comment? Let us know. Okay? So it should not be personal. I'm talking to all of you. You should also talk to me, and you have the right to bring your hand out and let me know. Okay? So therefore, periodontitis can be like this. In other words, the gingiva looks normal, but there is bone loss. Now, how do we know that there is bone loss? Because we get X-ray and we see bone loss. Now, is there another way to detect periodontitis? Yes. What is that? Is using your probe, going to CEJ. If you can detect CEJ, and then from that point down, you can measure, then you know that there is what? There is bone loss. In other words, it is attachment loss. So When there is attachment loss, do we automatically call it periodontitis? According to 2017, no. According to 1991, yes. We went for attachment loss. There was attachment loss, then we decide that this case is periodontitis. Right now, you should have also bleeding on probing and pocketing interdentally. By pocketing, we mean that there should be probing depth of 4 millimeter or more, and bleeding on probing. Then there is attachment loss, it is called periodontitis. Otherwise, it is not periodontitis. So by now, we go and determine whether we do have periodontitis. How we determine? We measure pocket depth, interproximal pocket depth. We get 4 millimeter. If we see also bleeding on probing on that point, we count it as periodontitis, as a tooth with periodontitis. Then, so this is periodontitis. Now, then we need to determine whether it is localized or generalized. By that we mean that we need to count the teeth with 4 millimeter depth and bleeding to see how many teeth we have. Then we divide by the total number of teeth times 100. It will determine whether it is generalized or localized. How it determines? So when you see more than 30% teeth with that situation, it is generalized. When you see less than 30%, it is localized. So up to now, we determine that there is periodontitis localized or generalized. Then severity. For severity, we go for attachment loss. For attachment loss, therefore, you will see in new charter, which the student do. They need to measure attachment loss per area with 4 millimeter or more pocket depth. So you will see cal, which is on the third row, a number. So then we go after those numbers. The worst number will determine the stage, the severity of periodontal disease. So this is the difference with the previous one. Previous one, we checked each attachment loss and we categorize, okay, now we have generalized, slight, and then localized, whatever. Now, no, stage is severity. Severity is the worst situation we see in the mouth, the teeth with periodontitis. So yeah, bleeding on probing. Here is very important, which I told you before that it was not like that. Now, exudate, pus formation. In periodontitis, we have pus formation. Do we have pus formation also in gingivitis or in healthy tissue, or we don't have? So this is another thing. Now, remember that according to the new classification, when they call a tooth with periodontitis is when there is what? 4 millimeter depth and attachment loss and bleeding on probing at the same site with 4 millimeter or more depth. Then that is periodontitis. The rest is not periodontitis. In other words, if you do have attachment loss, which is on direct, because of recession, then it is not called periodontitis. They call it is because of what? Because of trauma from toothbrushing or whatever. In other words, traumatic, it will not be categorized under periodontitis. So these are the difference which you will see. Now, attachment loss. When we talk about attachment loss, we know that apical migration of junctional epithelium happened. Attachment loss will be seen if there is bone loss, and also attachment loss will be seen before bone loss. We need to have what? We need to have degradation of gingival connective tissue. In other words, gingival connective tissue will be destroyed, and also periodontal membrane, periodontal ligament also will be destroyed, and bone. So in other words, when you see attachment loss is because of these things, is because of, destruction of gingival connective tissue. We know that gingival connective tissue, this destruction happens, and then it will form more apically. But before that, there is a need for apical migration of junctional epithelium on the root surface, so that you can get what? You can get destruction of gingival connective tissue, destruction of periodontal membrane, and destruction of bone. So whenever we talk about attachment loss, you should know these things happened. So radio evidence, periodontitis. Periodontitis, now, can you say that a case has periodontitis, but the X-ray shows almost no bone loss? Yeah, you can say. Why? Because it is interproximal area, and you know that sometimes there is a defect or whatever interproximal area you can't see on the X-ray. But you can detect by what? First of all, there is bleeding on probing. Secondly, there is pocketing, 4 millimeter and more. And thirdly, there is what? Attachment loss. So in other words, the last sentence is called by attachment loss. So, but basically, when you see bone loss, you know that there is periodontitis in case there is pocketing right now. But in the past, no. When we saw bone loss, we said, okay, periodontitis. But right now, no. And even in the book, it is also there is a sentence that usually you will see 1 to 2 millimeter attachment loss on most of the dentition, which is even healthy. So now healthy is different. Now, loss of attachment, in this case, you cannot see loss of attachment, but when they open it, you will see that the bone has been gone and bleeding and so forth. Actually, there is, instead of bone, what do you see instead of bone? In place of bone. They removed it here. It is granulomatous tissue, which in surgery, they will remove it. And sometimes it is difficult to remove that. So now, okay, characteristic of periodontitis, absence of pain. That is why the patient doesn't pay attention to that, doesn't know something is going wrong. And even when we detect periodontitis, they are hesitant to get the treatment because they think that they are normal. So now, extent and progression, periodontitis. Extent means that is it generalized or localized, which I told you how we go about that. We count those teeth and so forth. Now, progression is when we know that the periodontitis progressed or not in maintenance phase. We will see progression if we see the situation gets worsened. In other words, we get more area with 4 millimeter depth or more and bleeding on probing, or we get at the same site which was 4 millimeter, now it is 5 millimeter. So we know that there is progression. And in the new classification, they are using grading to denote progression, which is grade A, B, C. Now, I do have an example here. Book has good example. Now, so untreated periodontitis, according to the general idea, is it will go very slowly. And usually it has period which it is active, period which is inactive. It is not continuous. Now, we do have, and also it is site-specific. In other words, it is not all over the mouth. You will see in some area periodontitis, in some area it is health in the same patient. Now, we do have some form of periodontitis which it goes more rapidly. So in that case, in the past classification, they used the term refractory periodontitis and also aggressive periodontitis. Now, aggressive periodontitis means that, it is going very fast in spite of whatever you do. Now, in regressive periodontitis, it means that the periodontitis you treated or we treated and it was okay, but it came back. Now, when it comes back, it is called what? In those days, they call it what? Regressive periodontitis. Or let me see the right term which they use it. Okay. So, yeah. Now you see for progression. Oh, this is very important. Compromised periodontal maintenance. Compromised periodontal maintenance is when you can't attain the goal which you want. Usually what goal you want when you treat a periodontitis patient. You want to make sure that the disease is stopped. How you know that? No bleeding on probing, and also you have decreased pocket depth, but sometimes you can't get it, and you know from the beginning. Why you can't get it? There are certain cases. Now, if the patient is not cooperative, you know that you won't get the result. You do your best, but patient doesn't care, so therefore you do compromise maintenance. In other words, you will say, okay, this situation with this much pocket depth and so much bleeding, I am following to see what happened. So you will see more regular, and in these cases, usually you put on compromised maintenance, which is a serious health condition. Patient has serious health condition. We cannot do surgical procedure for pocket elimination, or advanced age, or severe periodontal disease, or severely reduced periodontium. We know that if we want to eliminate pocket by surgical management, then tooth will be loose, and it is better not to do that. Therefore, we do compromise maintenance. In other words, we don't like to see that situation, but the best option we can have for that patient. So, yeah, recurrent form of periodontitis, I talked about that. It's over here. You arrest it, but it comes back. Now, recurrent form of periodontitis, risk factor are these: prior history of periodontitis, poor self-care, and then non-compliant, patient which is non-compliant. So you can anticipate that periodontitis will come back. Now, staging and grading system, I talked about that, about interdental area, about facial and lingual recession, which they don't call it, they don't categorize under the section of periodontitis, if it is because of toothbrushing or because there is class 5 decay and then the gingiva has receded, or they extract a wisdom tooth and at the distal side of the last tooth, the terminal tooth, there is attachment loss because of the extraction. So they don't classify those under periodontitis. They classify under periodontitis when interproximal area you do have 4 millimeter depth, you do have bleeding on probing and attachment loss. Because you might have 4 millimeter depth, but you can't detect CEJ, it is gingivitis. And that's because of what? Because of coronal proliferation of the tissue. So clinical attachment, definition of clinical attachment, here in this slide it talks about that, which I told you, vertical root fracture I didn't mention, but that's another thing. So, so staging, I talked about staging. Staging is about severity and also about complexity of management of the case. So then we do our staging. Now, do you have any question? No, you. No? So let me know. So whenever you don't get my point, don't hesitate. Let me know. Okay? Because I want all of you to know what's going on. Okay? So now, next one. Okay. Now, okay, stage, I talked about stage. Now, stage 1 is when there is periodontitis and you can't get attachment loss more than 2 millimeter on any of those teeth with periodontitis. In other words, 1 and 2 millimeter attachment loss and the tooth has periodontitis, it is stage 1 on any tooth in the mouth. Now, stage 2 is when you can get, the most which you can get is 4 millimeter attachment loss on any tooth which is qualified for periodontitis. In other words, 3 millimeter and 4 millimeter attachment loss makes stage 2. Stage 3 is when you can get attachment loss of 5 millimeter or more on any tooth which was qualified as periodontitis. Then it is stage 3. Stage 4 have the same criteria. In other words, you will get 5 millimeter or more on any tooth. So remember, any tooth. You might have 20 tooth which has severity as stage 1, but you have 1 tooth which has stage 4. Stage 4 is when you do have 5 millimeter or more on any tooth qualified for periodontitis. And beside that, you should have this situation, mobility type 2. If you see mobility type 2 on this qualifying tooth, then automatically it will be stage 4. Now, also posterior bite collapse. When they extract a molar in posterior area and the adjacent tooth moved forward, collapse happened. If that tooth is qualified for periodontitis, then automatically stage will be stage 4. So now again, if you do see flaring of teeth and the tooth is qualified, remember this is very important, tooth should be qualified for periodontitis. In other words, 4 millimeter pocket depth and bleeding and probing. Then again, that case will be automatically grouped under stage 4. Now, also, if you do have a patient which there is only 20 teeth in the mouth, 10 on upper, 10 on lower, because of periodontitis, patient has lost those teeth, then automatically, and the tooth is qualified for periodontitis, it will be classified as stage 4. So now you should know between stage 3 and stage 4. What's the difference?
Mobility.
Yeah, mobility type 2, excellent. It can be either of these things. Posterior bite collapse, flaring of the teeth, which is qualified, then teeth which are just 20 teeth or less in the mouth, the rest was lost because of periodontitis. It will be stage 4. So that's staging in this system, 2017. And they are using the same staging. In other words, they are using, the staging they use in medicine for cancer. So, in here, you do have in the book also pocketing and also attachment loss and other criteria. So, anyhow, this is what. Now, can you call this right now periodontitis or not? Again, it depends on pocketing. if you can't get pocketing, it is just 2 millimeter, 3 millimeter, you do have so much recession, you can't call it periodontitis. But if you get pocketing, then it is qualified for periodontitis. Then you determine whether it is generalized or localized, and then stage you go for the worst tooth qualifying for that. Now, this is one case of periodontitis, which is, periodontitis grade 4, and then, no, this is not, the previous one was not grade 4, but this one is grade 4. According to that, of the amount of probing depth, bone loss, and so forth, you do have it in the book. I just put it, yeah, like that. Now, so grade, and also we do have grade. You have staging and grading. Grading, we do use grading when we follow the patient. In other words, you are following the patient for maintenance. So if you see in 5 years nothing has changed, then it is grade what? Grade A, the best grade. Now, if you see in 5 years it is about 2 millimeter loss of bone, then it is they call it grade B, and then if it is more, they call it grade C. So that's grading. Right now, we are not using grading because the student is getting the patient right away. But in your situation, you do have, I think you do have a patient from before, but again, it doesn't belong to you, so it is difficult to determine whether it is grade A, B, or C. But grade goes according to the progression of the disease. Then they use grading. Now, periodontitis, I talked about periodontitis, which is one form of the disease. Now, the other form is necrotizing periodontal disease. You remember, according to 2017, we do have necrotizing periodontal disease, we do have periodontitis, and we do have, what else we do have? Periodontitis as a direct manifestation of systemic disease, okay, under those. Now, this is necrotizing periodontal disease. Now, this condition is painful. Anyhow, periodontitis is infection. Now, this condition, which is necrotizing, is painful infection. Now, is this necrotizing periodontal disease also by biofilm, plaque, or by something else? Which one? This is very important. It is not by biofilm. It is by other, which I talked about that, which it can be Neisseria, it can be gonorrhea, those kinds of microbes. So, therefore, this is very important. In other words, the etiology is not the same as plaque biofilm, which we do have in periodontitis. And by the way, you should know that periodontitis, we need to have gingivitis first, so that we get periodontitis later on. In other words, it doesn't come right away, periodontitis. No, it starts with gingivitis. So it is very important to pay attention to periodontitis and to treat that so that the patient doesn't go to the next stage, which is periodontitis. Now, we know that periodontitis is started by plaque accumulation, but it is the reaction of the individual to those bacterial, byproduct which cause what? Loss of bone, loss of connective tissue, loss of periodontal ligament, which is named periodontitis. So we need to remember this one. Now, in necrotizing periodontal disease, you will see ulceration. In other words, one character is ulceration. Now, you will see sloughing of dead epithelial tissue, also fetid odor. So these things now also systematically lymph node get involved. in most of the cases. Now, necrotizing periodontal disease can be necrotizing just gingivitis. Now, I need to remember the time. I think I have 10 more minutes. To the gingiva, it is called what? Necrotizing gingivitis. This is a case. Now, you see, we do see punched out papilla. Punched out papilla means that in between the teeth, in interdental area, you see this situation. Punched out papilla. So, also patient is painful. These conditions are painful, and it is destructive. Okay, so that's what necrotizing gingivitis. We do have necrotizing periodontitis. In necrotizing gingivitis, you can't get attachment loss. In other words, just gingiva is involved. Now, in necrotizing periodontitis, you see rapid destruction of bone, necrosis. You see necrosis and so forth. Necrosis of bone, necrosis of periodontal ligament. You will see, and how do you see in the mouth? Then you see like that. This is necrotizing periodontitis because you see the root, you see punched out papilla over here, and it is very painful for the patient and for you also when you check at that. Now, then it goes about etiology, oral sign and symptom, which I put it that, and I talked about that. You will see pseudomembrane formation. When you hear pseudomembrane formation, what it is consist of? Pseudomembrane. It is consist of pseudo and membrane. Yeah. Okay. So membrane. What is membrane? It is mem and brain. Yeah. The brain and easy. Yeah. Okay. So in other words, so in pseudomembrane you have what? Dead tissue. Dead tissue is consisting of what? You know that there is reaction in the body, and those white blood cells, dead white blood cells, you will see dead epithelial tissue, and we know that in this necrotizing periodontitis also bone will get involved, periodontal. So pseudomembrane, when we talk about that, we will have those things. Now, then you need to remember that usually the first area which is involved in necrotizing gingivitis or periodontitis is interdental area. And you see punched out papilla. Okay? So, next one. So pseudomembrane. You see these things in pseudomembrane. Okay? So which part is pseudo, which part is membrane, then it is up to you to decide. So masses of bacteria. Now which type of bacteria, then you need to do a study and get to see which type dominate in a case or something like that, which it can be a good study for whoever is interested. Okay? Now, then the other topic which we have is gingival soft tissue recession. These are what? According to the classification, we do have what? Periodontitis, which they classified in that. Then we have peri-implantitis and conditions. Now, what are conditions? Condition, one of them is what? Recession. Recession is condition, okay? So we do have mucogingival deformities and condition. It is part of this classification. Now, mucogingival deformity is deformity between mucosa and gingiva. Now, what are those deformities? According to Dr. Goldman, 3 things is mucogingival deformity. One is high frenum attachment. The second one is shallow vestibular depth. And third one is pocket traversing mucogingival line, according to Dr. Goldman. Mucogingival deformity is like that. Now, according to the new classification, 2017, mucogingival deformity and condition, they consider also recession, gingival excess, which can be because of what? Because of medication, or because of genetic gingival excess. They classified it under mucogingival deformity and condition. So these are conditions. In other words, recession is condition, but they put it under mucogingival deformity and condition. So recession patient, what is the sign, what is the symptom of recession? Sign, you can see the root, which the clinician considers the root. Now, symptom of recession, some patient, yeah, the root is shown, but no complaint. Some patient, sensitivity. Sensitivity to what? To cold and to hot. Now, then some patient, they get interested because it is in aesthetic zone, and they see the root. Okay? So that's another thing. So, Debbie, here you go. Now, do you have anyone blank? Because somebody wants a blank one.
A blank one what?
Blank one of these questions. Do you, how are you doing?
A blank question.
You know, this one.
There's blanks in there. I printed more than I needed.
Oh, you put it? Okay, so we have no problem. Okay. So, this is about condition. Now, then we do our classification for recession. Two classification for recession is in the book. One is Miller classification, which goes by, which doesn't go by attachment loss. The other one is Cairo classification, which goes by attachment loss. Now, in Cairo classification, when there is recession, okay, so pseudo pocket, we called about gingival excess in the new classification condition, pseudo pocket and so forth. Now, normal microgingival. Okay, about biotype. About biotype, I need to say that. We do have three kinds of biotype. Right now, they use the term phenotype, not biotype, because biotype goes back to genetic. Now, in phenotype also, environmental factor will be considered. Now, we do have thin scalloped, thick scalloped, and thick flat gingival biotype. So check that. This is about biotype. Now, this is which type of biotype? It is thin scalloped. It is scalloped, you see, it goes like that, and it is thin, and the gingiva is thin. Now, then I wrote down what criteria the tooth should have. In other words, the contact point area is near incisal area. Now, then I think I should use, okay, now. Then thick flat biotype. Thick flat biotype, you see, in other words, it is not so scalloped over here. It is flat. It doesn't have that arcade, and it is thick. The gingiva is thick. So it is thick flat. And then we do have thin flat biotype, the third one. Okay. Now I need to show that it goes. Okay, so here we do have what? You do see recession. Now classification, according to Cairo classification, if there is no attachment loss interdentally, and then there is attachment loss on direct, it is called class 1 Cairo classification. Now remember, we are talking about in Cairo attachment loss. They use attachment loss. Now in class 2 Cairo classification, which I do have it, I mean, right now I might not have the time to go over that, but yeah, I think I don't have. But you will see. In class 2 classification, again, what you see? You see there is attachment loss on direct. Interdental also there is attachment loss, but it is less than attachment loss on direct. It is Cairo 2. Now, Cairo 3 is when attachment loss, interdental area, is more than on a direct area. It is called Cairo 3. It is very simple. They use attachment loss. In Miller classification, we do have 4 classification, 1, 2, 3, 4. Now, the 4th one is when there is attachment, there is recession interdentally and on direct, and actually on the interdental area, there is more recession than on direct. Now, the classification 1 is when there is recession just on direct, but no recession in the proximal area. Now, class 2 is there is recession on direct, but passing mucogingival line, and there is no recession interdental area. Class 3, you will see also interdental area recession. Those are Miller classification, but nowadays they use Cairo classification. Now, maybe in future you will have Alexandria classification, yeah, because Cairo, the Alexandria. So anyhow, so I think my time is up, and basically I went over the whole things. Okay. Go ahead.
So this says necrotizing periodontitis. So it says the most severe biofilm-related periodontitis. So is it caused by biofilm?
No, the biofilm is there, but usually there is some other thing.
Is a systemic thing?
Very good point.
Okay.
Very good.
All right. Okay. Thank you.
I'm proud of you. Very good.
Thanks.
Very good. You pay attention. Good. Great.
Didn't get to sign this.
Okay. Okay, David. So,
Sorry. Here's your result.
yeah. So, we need to count them.
Only one once. Only one once. Everyone else once. Less PowerPoint, more notes.
That's what so did you count that?
I pulled all through them. All of them want that except for that one on top.
So in other words, you have the result, yeah?
All of them want except for the one on top.
Wants what?
She wants 2. Everybody else wants 1.
What? Each one.
Thank you.
Yes.
Just confirming. So 12:45. So I can meet with him at 12:45 today.
Yeah.
Okay.
Yeah, sure.
Okay. All right.
So you come 4:16. Is that 4:16 my office?
You're 4:14.
4:14. Okay.